Good afternoon. My name is Chris Deeran. I'm Director of Reform Scotland, and I'd like to welcome you to today's event. Can I just ask anyone who isn't either me or today's guest to mute themselves so there's no background noise? That'd be very helpful. I'm also aware we're competing with the budget, but Reform Scotland is nothing if not too big for its boots, so here we are. And anyway, thanks for choosing what some might consider the saner option, even if it might not necessarily be better for the blood pressure. The NHS is at the very top of voters' lists of concerns, a space it shares only with the economy and the cost of living. I think even before COVID and lockdown, it was pretty evident that the trajectory of healthcare in Scotland was veering towards what some might describe as unsustainable. The impact and the consequences of the virus have only worsened that situation. I think it was the winter before last that I noticed a distinct change in the nature of the debate. We're all used to the annual winter crisis, but that was the first time I'd really noticed a phalanx of medics as opposed to the usual patients and politicians starting to speak out publicly about the forces that were ranged against the NHS, how badly it was struggling, and even to question its medium and long-term viability unless action was taken. That strain of daily precarity and the lack of leadership or sense of hope that was maybe coming from the centre was clearly becoming too much. GPs were writing crisis diaries for newspapers, consultants were penning op-eds, everyone and their auntie was appearing on the nightly news, and that was definitely something that jumped out to me, that maybe we hadn't quite seen it on that scale before. This urgency didn't seem to spark a commensurate response from government, though. The BMA, whose Scottish chair, Dr Iain Kennedy, is our guest today, started asking for a national conversation on NHS reform about this time, a broad, thorough public discussion and debate about the challenges facing the NHS and what reforms might secure its future. Ministers who were at that time perhaps too preoccupied with various crises of their own didn't seem to bite. It was early last year then, I think early last year, that the BMA approached Reform Scotland and suggested that our think tank might, to the best of our limited capacities, provide the space for a version of this discussion to begin. And this was timely for us. We'd long been wanting to tackle NHS reform, but had struggled to find a way in and the people that could help us to undergo that process. At the same time, we were increasingly being approached by various people from within the healthcare system, expressing their frustrations and their desire for change and asking what might be done. So as a result of all this, we launched NHS 2048, which is a work programme that is drawing thoughtful and innovative contributions from all sorts of smart people, medics, academics, reform-minded politicians, those working in the private healthcare sector. And we want to get as many ideas, good, obvious, odd, brave, unlikely, whatever, out there into the world as possible, especially before the politicians descend, narrow the parameters and start to tell us what can't be done and attempt to get away with the minimum possible. There's a process that we should go through before that. This isn't to deny that fixing the NHS isn't fiendishly difficult. Of course it is. But equally, we really have no choice. Anyway, you can find all the work that's been done so far on our website. There's much more to come. And actually, if you'd like to contribute, all you need to do is drop us a line. We are open to letting 1,000 flowers bloom. So if you have a thought about how to reform the NHS in whatever way, in whatever part of the NHS, get in touch and we will accommodate you. I think it's fair to say that NHS 2048 has easily been the most popular and engaged with programme we've undertaken, which tells us something about the appetite around the issue. It also tells us that the crisis isn't approaching, it's here. Action needs to be taken now if the NHS is to reach its centenary in 2048 in any sort of good health. Patients, taxpayers and the sector's workforce deserve no less. I'm not sure how many of you will have noticed that the Scottish Government finally committed to the BMA's national conversation in last December's budget. It was quite easy to miss. It was a single sentence slotted somewhere in the middle, which, as far as I can tell, hasn't been followed up on so far. And we're now on to yet another health secretary who must get up to speed with this most complex of subjects. So who knows when or if we'll finally see some progress. Anyway, we thought it would be useful to have a public conversation with Iain to explore some of the issues at hand. As many of you will know, Iain became chair of the BMA's Scottish Council in August last year. He's already proven himself a forthright and outspoken advocate for reform and for the rights and interests of the BMA's members, which is as it should be. Iain is a GP from Inverness, executive partner of Riverside Highland Medical Group. He has worked as a GP for 25 years and been an elected member of BMA Scotland for almost 14 years, sitting across a number of committees, including the BMA's UK Council, its Scottish GP Committee, UK GP Committee, and Scottish Council. A Highlander and former non-exec director of NHS Highland, Iain was also the lead whistleblower on the bullying culture, which led to the Sturrock Review of NHS Highland, which gives him the kind of form and appetite for troublemaking that suits not just the moment, but definitely appeals to the journalist in me. So I'm very pleased to know that about you, Iain. As the event progresses, we'd very much like to hear from you, your observations and questions. So if you'd like to contribute, please let us know using the Zoom chat button, and we'll try and get to you. As ever, these things work best as a conversation. And so welcome, Iain. It's quite hard to know where to start, given the sheer scope of what the NHS is facing. The dashboard seems to be flashing red wherever you look. So perhaps I could start with quite a broad question and ask you to capture the scale of the crisis for us. We can get into the roots of it as we go on, but broadly, how big is this challenge? Is it genuinely existential? And maybe give us a flavour of what it's like working inside the NHS at the moment.
Thanks, Chris, and good afternoon, everyone. And thank you very much for this invitation. And I'm looking forward to our conversation. And just a wee correction, if you don't mind, I've been in post for 18 months, so it was August year before last.
I misread the date, apologies.
Wouldn't have been able to create so much trouble in such a short space of time. So when I came into post in August 2022, I went straight out to the media and said that we had 5 crises in the NHS in Scotland. And these were around doctors' pay and pensions, around workforce planning, around workload and working conditions. And the reason I went with those 5 was because that's what my members in Scotland were telling me. That's what doctors across Scotland were telling me was the problem. And then towards the end of the year, we were listening to what Audit Scotland were saying and what they're still saying now, and we were gathering together our own personal experiences. And what was absolutely clear was that the NHS in Scotland is not sustainable in its current form. I was quoted as saying that some of my members were saying that it's dead already, dying on its feet. These were the sort of things the membership was telling me. And it fitted with my own experience, and it fitted with what people were telling me up and down the country. And I think for the first time, nobody was disagreeing with what we were saying, including the politicians. Now, in this short time, 18 months, I'm now onto my 3rd Cabinet Secretary for Health, and I'm taking no personal credit for that. But I've yet to meet Neil Gray. It's imminent. He has been in touch with me. But Hamza Yousaf and Michael Matheson, they both fully acknowledge the problem. So we do have an absolute crisis. And I think if I go back to Audit Scotland and what they said last week, it's not sustainable. Capacity is not meeting demand. And we've got cultural problems as well with healthcare professionals not feeling that they're able to speak up. But most of all, I think the most damning thing that Audit Scotland came out with is that there is no plan for the NHS in Scotland. And it seems unbelievable that there is no vision, no strategy, no plan for NHS Scotland. Even the small building that I'm in here, Riverside Medical Practice with 10,000 patients, we have a vision, a written down strategic plan that we review every year, a small GP practice. To think that NHS Scotland has no vision, no plan, seems quite incredible.
And that is extraordinary to hear you put it so starkly. I was going to ask whether our politicians understand the scale of the crisis, and I don't suppose what you've said negates that question, because one thing would be, is the government being honest with the electorate about the scale of the problem and the challenges that lie ahead? I mean, the NHS to me has always seen, or certainly NHS reform has seemed hamstrung by party and constituency politics. It really is the ultimate political football. It often seems to take the media or think tanks like ours to reveal the truth about what's going on. So what's your judgment about where politicians are on the NHS, the truth about the NHS, being honest with the public, being open about the scale of the challenge that lies ahead of us?
Yeah, I think honesty and truth cut to the heart of it. And you know, you mentioned that I was on the board of NHS Highland, and if I think to just before I went on the board, so way back 2008, 2010, and that's when Nicola Sturgeon was the Cabinet Secretary for Health, just around about then. I think Shona Robson came in. But we were seeing some improvements, definitely, Scottish Patient Safety Programme, and there was a sense of optimism then, and a few of us, you know, really engaged with the positivity. I got involved in a few projects, and it was actually quite exciting, and we thought we were on to something big, and that Scotland's NHS could be the best in the world. That was what was being presented to us, and we genuinely believed that we could be the best in the world. But things seem to take a dive down, and I'm not directly linking it to Nicola Sturgeon becoming First Minister, but it seems to have happened around about that time, probably coincidentally. Things seemed quite good when she was Cabinet Secretary for Health, and then afterwards things nosedived a bit. And what I noticed was a complete lack of openness and honesty. And I'll give you an example. I was noticing that my patients were waiting longer and longer for hospital appointments. So I started asking in my own health board, in various medical committees, I started asking the executives on the board if they could give us a breakdown of waiting lists so that we could tell our patients. And they wouldn't give that to us. And I kept pushing, and they said, well, we'd be the only board in Scotland that would be doing it. No other board publishes its waiting times. So I kept pushing. And then I was sitting in a meeting in NHS Highland, and up on Twitter came, it was one of the NSS Scotland or one of these specialist health boards came up with the waiting time figures. So it was in they wouldn't give it to me, somebody who was working as a clinician in NHS Highland, but it came up publicly on Twitter with all the waiting times across Scotland. And of course, NHS Highland was worst for just about everything. And that told me that we had a real culture of secrecy in the NHS in Scotland. And I think that's been a feature that I have seen over the past 10 or 15 years, a culture of cover-up and secrecy where the public were kept in the dark, but also when I was a non-executive director, I had a sense that we were kept in the dark. And I think you're right, your observation that people started speaking up the winter before last, that's when I started speaking up. And all I did was state the obvious. And suddenly everyone started saying to me, oh yes, we all know what the problems are. It was as if they were saying to me, Ian, the BMA is pointing out all the problems. We all know what the problems are. We're needing solutions. But actually, nobody had been declaring what the problems were. It was cover up. There's lots more I could say on how things are hidden from the public, but maybe let me just give you one example before I let you speak again. So in the Highland, our biggest practice by far, all in Essendon and Gordon, about 15,000 patients in a very deprived part of the Highlands, fell over. All the partners left. It didn't even grab a headline. You know, a massive practice, very deprived area, right in the sort of area that our government would believe we should be prioritising healthcare. It didn't get a mention. The health board kept it quiet. The government kept it quiet. I tried to get it out, struggled a bit to Channel 4 were interested for a bit, but struggled to get it out. So it's that sort of thing that's hidden. Now, if that happened in the centre of Glasgow, the biggest practice in Glasgow, or the centre of Edinburgh, would it be quite so hidden? So these are the small things going on everywhere now in Scotland. It started in Highlands, we're a bit further away, but all over Scotland, we have practices falling over and hospital departments that have vacancies.
And what, as chair of BMA Scotland, you're obviously getting FaceTime with ministers, civil servants, and the rest of it, even if you're still to meet Neil Gray. I'm sure you have these conversations with them. I'm sure you're as forthright with them as you're being with us today. What kind of engagement level or response do you get in those conversations?
Yeah, so we do have a very positive relationship with the the government. And our meetings, if you were a fly in the wall, you'd see very amicable meetings with good relationships and good atmospheres. So the relationship that I and my colleagues built up with Hamza Yusuf was a very good one, and likewise so was the relationship with Michael Matheson. So we were all disappointed when each one moved on, because we were just getting somewhere with them and hoping to move into new territory. So they listen, they acknowledge what we say. A lot of the time, it does come down to money and lack of resources. So that will often be the stumbling block. And obviously, as a trade union, we go in talking about pay, we go in talking about pensions, but also about unsustainable workloads and working conditions and culture. So we have good relationships. The Cabinet Secretary will invariably tell us that they can't give us everything, which I sometimes interpret as we won't give you anything at all. But I haven't had a long enough relationship with any Cabinet Secretary yet to say that we're truly making progress. But one thing that I will give Hamza Yusuf and Michael Matheson in particular is the fact that we did avoid strikes in Scotland. That was a success. And between Chris Smith, my junior doctor's chair, and the government, we did protect the public from strikes in Scotland, but that's only been averted in the meantime. So positive relationships with the government, but not a huge amount of progress.
Okay, well, let's dig down a bit into some of the detail, and I'd like to start by talking about the workforce, which obviously without the workforce there is no NHS. And statistics released this week showed that consultant vacancies stand at, I think it's something like 436 posts, which is up by around 6% on this time last year. And on top of this, posts sitting vacant for 6 months or more are up to 238, which, and I'm reading this obviously, a 12.2% increase over the past 12 months. If we can just focus on the consultant area, there is clearly a problem recruiting senior doctors in that area. Now, these are, well-paid posts, relatively speaking. They have a high status. Every mother would like their son to be a consultant, etc. What's going on?
Yeah, so those figures are stark, and that's only half the story, because that's the government's official figures. So that 436 number, we at the BMA think it's probably double that, because with these government figures, they don't include posts where there are locums in place, and they don't include posts that they're no longer advertising because they haven't managed to fill them. So we always go in with a freedom of information request at the same time as the government comes out with official figures. And I can let you know that Greater Glasgow and Clyde have not provided us with any information. So back to my mention about cover-up and secrecy, the biggest health board in Scotland hasn't even given us the true figures. And I believe the Information Commissioner is now involved. So things are probably twice as bad as you've described. Why is that? Well, consultants are quite well paid, but they're not that well paid if you compare them to other professionals like engineers, like lawyers. My twin brother's a lawyer. I know what he earns. It's more than double what I earn. He deserves it. But doctors, maybe we used to be well paid compared to others in society. We're not really anymore. And because of vacancies, the pressures are far greater. So the jobs have become less attractive. And as departments lose doctors, everyone else gets a bit unsettled. Doctors are voting with their feet. We sometimes focus a bit too much on strike action. What doctors are doing is way beyond strike action. They're retiring early. They are reducing their hours. They're emigrating. So huge problem with consultant vacancies. And if we focus again on pay, doctors in England earn more. They've just been given a pay offer this week. And if we also add in the fact that doctors in Scotland are taxed more, it's considerably more attractive now to be a consultant in England than it is in Scotland. And if young doctors are making a choice, and they just look at the hard facts, the pound signs, they're going to choose a country out with Scotland. So that's consultants. And I can say hot off the press that Neil Gray, the Cabinet Secretary, has today agreed to meet the chair of the Scottish Consultants Committee, Alan Robertson, and Sheena Steele, who's the chair of another one of our committees. It's called the Staff and Associate Specialist Committee. So those two doctors have been invited to meet Neil Gray, and I'll probably be going along with them to perhaps talk about direct negotiations on consultant pay. Can I maybe go on and talk about GP vacancies?
Well, I was going to come on to that, because in your own area in primary care, we've talked about this before, that there simply aren't enough GPs, and I know you've experienced this in your own practice and business as well. So just for context, in December 2017, the Scottish Government pledged to increase the number of GPs in Scotland by at least 800 between 2018 and 2028. 6 years on from 2018, only 11% of that target has been reached. Meanwhile, in real terms, after adjusting for part-time work, which you touched on, the size of the GP workforce in Scotland has shrunk by 5.4% over the past decade, while the number of patients registered has increased by 7%. So all these stresses and strains coming in, more patients, fewer GPs, not enough GPs. What's your experience as a GP and trying to run a GP's business as well?
Yeah. So I think it was in 2018 we were promised, I think it was 800 GPs by 2025. And as you pointed out, the numbers have gone down. So the population size is increasing. The frailty of the population has increased. The demand has gone up. And during that time, numbers have gone down. And that's put huge strain on general practice, including my own. We have only just survived. Over the past few years, we've seen doctors we're in a very competitive environment. Doctors get poached by other practices. So we've had doctors poached, and then we've had to go and poach from other practices, really competitive to get doctors. And we've only just managed to survive. And what we did, and it's turned out to be a very positive thing, is we've recruited 8 advanced nurse practitioners. So we have 10 partners, 10 GP partners, but we're across 4 practices. I've got 2 rural practices, one in Foyers, one in Cromarty, and another smaller practice in Inverness. So we've got 10 partners, 8 advanced nurse practitioners, and we have just survived, but with a very can-do attitude. But meantime, we have seen practices across Scotland fall over. And if I just talk about Highland, that's where I am just now. There are no permanent partners in the main practice in Wick, nor in Thurso. Most of the west of Scotland, Durness, Kinlochbervie, Scourie, lost all their GPs, but you don't hear anything about it. Skye struggles to get GPs. Orkney, Shetland, Western Isles, Grampian, even Grampian, city centre Aberdeen, practices closing, rural Aberdeen really struggling to get GPs. Now, this was unheard of. It used to be that when you were a young doctor looking for a GP partnership, it was dead men's shoes. That's what used to be said. It was really difficult to get into a partnership. And there would be queues of GPs for every vacant post. There'd be queues of us trying to get in. Now we are going out almost begging, literally almost begging people to join us. Now, the impact on this on patients is massive, because it means that they are not getting the same continuity with their doctors, and they're waiting longer to get access to a GP appointment. And we know that continuity, and this goes for hospital consultants as well, we know that continuity with one doctor is the biggest predictor of a positive health outcome for patients. So if there's one bit of advice I'd be giving to the government, it would be invest in permanent doctors in general practice and in hospitals. Stop wasting money on expensive locums because you're too tight-fisted to pay a little bit more for permanent staff.
And it's not just, I think, in terms of the existing doctors, there's also an issue with the number coming through, that the number of medical students has fallen I think there are even problems recruiting the amount that universities are looking for. What do you understand is going on there?
Yeah, so I was quite surprised with figures I heard from NHS Education Scotland in the past month. So I think I'm right in saying there's 850 medical school posts in Scotland, and this year we've had something like 950 applicants. Now, the belief is that many of those applicants won't be suitable. They won't meet the criteria. So the prediction is for, I think, the first time ever, we will not fill all medical student places. Now, when I applied medical school in the late 80s, it was extremely difficult to get in. I think people used to say there would be 10 applicants for every place. So we've now gone to a situation where people are no longer choosing medicine. Now, there's been a little bit of criticism put in my direction because of some of the negative comments that come out from the BMA about being a doctor. But, you know, we believe that we've got to say things how they are. There's no point lying to school pupils that it's great to be a doctor in the health service at the moment, because it's not. You know, the patients are great. That positive experience dealing with patients is fantastic. But the overall life experience and work-life balance of being a doctor at the moment is not good. So I think there's, you know, we've got to be very concerned about the lack of youngsters choosing medicine at the moment.
And obviously, and I see someone's put a comment there about nursing and midwifery as well, that you know, there are just problems across the space, if you like. But I want to move on a bit from workforce now, and I'd like to talk a bit about the other side of it, which is the patients. You've been a doctor for, you know, a few decades now. I'm interested in how your conversations and the feedback you've received from your patients has changed over the years. So we know people grumble about struggling to see a GP or waiting too long for a hospital or a surgical appointment. What do you hear from people? And I guess, do people understand properly how the NHS works, that it is a ration system within the system that we've created? And I guess on top of that, as part of the reform conversation, do we need to have a much more grown-up and serious conversation with the public about what's achievable and what isn't within an NHS system?
Okay, so as you were asking that question, two of my patients came into my mind. And one of them is a patient who's currently dying from a terminal condition, and I saw him at home earlier this week. And I've been his GP for 21 years, and it was quite emotional. I don't often cry with patients, but I was pretty close to it on Monday. You know, he thanked me for being his GP for 21 years. And, you know, he's probably got 3 weeks left. And I thanked him for being my patient, and for being a good patient. And we've had many conversations over those years, mainly about football, and a bit about local politics, and, you know, consultations, when you're a GP especially, a lot of the consultation is about the individual, about their occupation, about their life experience. And he's told me amazing things about his life. And actually, he when I whistle blew, he actually phoned me up and said, "Is there anything I can do to help you, Dr. Kennedy?" And he said that's how close the relationship was. So that's this kind of really positive relationship that you can build up with a patient, and it certainly improves palliative care, having that long-term relationship. But I feel guilty that I can't see him as much as I would like to. And on the mention of guilt, another patient that I saw this morning who was sitting in seeing my doctor in training, my GP registrar, one of my patients, and I haven't seen her for years. And that's because she struggles to get near me. And, you know, she saw me, and I saw her as I walked past. And, you know, I've got a huge sense of, I'll introduce you to a term that you might have heard of, moral distress. And that is where we as doctors and healthcare professionals aren't able to deliver the care and the access that we would like to. So I've maybe got, you know, 1,500 patients that would regard me as their GP, but I just can't see them all, and I can't give them the continuity that I'd like to give them, and the access that I'd like to give them. So this moral distress, that gap between what they deserve, what we as doctors would like to give them, and what we can actually give them is quite big. And I think that moral distress and the moral injury that the whole profession, not just doctors, but all healthcare professionals are experiencing at the moment is massive. And we are constantly apologizing to patients. When patients come in and sit in my seat, they will say to me, let me make up one. So I'm going to refer a woman to gynecology, and she'll say to me, so Dr. Kennedy, how long will it be until I get my appointment? And I'll say, I'm really sorry, I have no idea. And they'll say, can you tell me what month it will be? I'll say, no, I'm really sorry, I can't tell you what month. Can you tell me what year it will be? You know, I can't even tell you what year it will be, whether it'll be this year or next. And then they'll get on the waiting list and they'll phone up the hospital and say, where am I in the waiting list? And the hospital will say, I don't know, phone your GP. So we're in this situation, constantly apologizing, but we don't even have the technology, basic technology, an app or whatever, where we can say to a patient in front of us, this is when you're going to get seen. So in terms of expectations, I would probably flip it over and say that we're failing patients. I don't think patients' expectations are too high. I don't think that at all. And I think the majority of our public are really respectful of our time, and they often stay away. And they learned during the pandemic to stay away. So I think we're failing our patients, and I think we're failing the population of Scotland. And it comes back to what I said about at the start and what Audit Scotland have said about capacity simply not meeting demand, and which is why, of course, we have called for a national conversation on the future of the NHS in Scotland.
And you touched on waiting times, waiting lists there, and the numbers around those make for pretty horrible reading. The number of patients on the elective waiting list in Scotland has grown by 87% since the start of the pandemic. The percentages of patients waiting less than 18 weeks for elective treatment and less than 4 hours in A&E departments have also fallen substantially since the start of the pandemic. Add to this, the ambulance service can't meet its target for reaching the most urgent patients within 8 minutes because of the delays in admission to A&E departments. Between 10 and 16% of hospital beds are occupied by people who are medically fit to be discharged but are stuck in hospital because of the lack of available social care services and care home beds. There's been a rise in people seeking help for mental health conditions, especially post-pandemic, but the system isn't remotely set up to cater for this level of demand. The issue seems so large and so broad that it's hard to even begin to think how you go about fixing this. How daunting is it for someone like you who's right in the weeds of this to start to kind of work your way through something so vast and so complex and entangled?
Yeah, it is daunting, and I don't know if you saw, or any of the viewers here saw Channel 4 last night. Kieran Jenkins did a brilliant graph of what's been going on in Scotland, and he went back to 2013 and extrapolated the figures to now, and all the waiting lists have got far worse. 2, 3, 7 times. In terms of waits, inpatient care, outpatient care, cancer waits, I think, are up by 7. And the only part of the NHS in Scotland that I think is doing better than other parts of the UK is actually the A&E waiting times. And there was a slight improvement in child and adolescent mental health. But things have got far worse since 2013. And back to what I was saying before about cover up. Why is it taking us until 2022 to start talking about this when it's been going downhill since 2013? And I can tell you that our experience as healthcare workers in the NHS, it's all been about saving money. That's all the health boards have been speaking to us about. And clearly, they have been advised from civil servants who have been advised by cabinet secretaries to focus on saving money. Now, of course, the public don't hear that quite so much, but there's been a drive to reduce staff and to save money, and not just healthcare staff, but support staff as well. At the very time that we should have been expanding our workforce, we've been reducing the workforce. And of course, you've been hearing a lot of talk over the years about inefficiencies in the NHS. Well, we've been trying to sort out efficiencies for 15 years. And if we think, if we haven't managed to become more efficient in 15 years, we're not going to fix it now. And I can tell you, in general practice, we're highly efficient because we've got to be. We just would not survive. And they're so thin on the ground in hospital departments and in wards. Any of you who have been in a ward recently will know there's hardly any nurses. The idea that we can sort this out through efficiency savings, that's not going to be the solution. So waiting times, waiting lists, all the metrics have got worse, and the workforce has gone down, which, and I'm going to say it again, which is why we've been calling for a national conversation on the NHS. Now, I did first mention that to Hamza Yusuf, and it was February last year, and he said that he thought it was a good idea. And he was just off to speak to somebody to get air cover. Not his words, mine. I'm not sure who he was off to speak to, but it was somebody more important than him at the time. Now, of course, then what happened, there was a leadership campaign. So that lost a bit of momentum. But Hamza Yusuf did put in his 6 points for his leadership. It was down at number 6 that he would start a national conversation. And then I'm going to tell you, I met with Michael Matheson and discussed it a couple of times. He was less keen on the idea. That was his words. He wasn't keen on the idea. But a couple of weeks later, Shona Robinson at the budget said that they were going to have a national conversation. So they've committed to that happening this year. And when I meet Neil Gray, which will be quite soon, hopefully sometime this month, I will be asking him about progress on the national conversation.
Okay, just another couple of questions. I mean, we could get a million questions, but I'll just do another couple, and then I'd like to take some comments from the audience. Is part of the problem the NHS's size and complexity? It's Scotland's largest employer. It's vast. Are there too many bureaucrats, too many boards, too much interference from above? You could talk a bit about culture, governance, accountability, whistleblowing, which, obviously you've been closely involved in. Sir Ewan Brown has written 2 excellent contributions on this to the NHS 2048 series. But how important is thinking about the way the NHS is structured at present and the blockages that might be there in the system to maybe doing things better?
Yeah, so I think the NHS gets described as a complex adaptive system. So it is all very difficult. In terms of, let me chunk this down a bit. So in terms of bureaucrats, managers, I don't think we're short of managers. And I think it's one of the myths. I have a positive view of management. I'm currently doing an MBA, and I've worked with many good managers in my time. In fact, the most important person in this building is our general manager, by far. More important than me as executive partner. They can replace me. You cannot often replace a really good manager. So I think we have some good managers in the NHS in Scotland, some not so good managers. There's no doubt that there are a lot of managers in the NHS. I'm going to say something quite controversial, but it needs to be said. I've certainly experienced many managers promoted above their level of competence. And I think that happens at board level. And we run into problems when that happens. So I think there is a competency issue, and we're probably recruiting people for the wrong reasons. We're recruiting them for their ability to deliver, their executive styles, and we're not recruiting them for compassionate leadership, and we're not recruiting them for expertise. There is a lot of evidence that if you put experts in leadership positions, they're more likely to be successful. And also if you put compassionate experts in leadership positions. So we've probably got the wrong people in a lot of posts, but we're not short of managers. In fact, I probably argue we probably need more rather than less. In terms of number of health boards, I think Labour are keen to reduce down to 3 health boards in Scotland. What would my members say about this? Some would be ambivalent about it, say it'll probably not make much difference. People like me and more rural health boards will become a bit more nervous because we'll think, we'll be ignored even more. If we become part of a big health board that's got a big urban area, then remote and rural healthcare will be ignored even more than it is. So restructuring, I'll give you a personal view. I don't think it'll make much difference, because we'll probably end up with the same number of constituent units and the same number of people. What we would reduce is the number of non-exec directors and the number of boards. Maybe not a bad thing, although I do worry a bit about command and control in Scotland, where government has a pretty iron fist on the NHS. And I think if there was less boards, maybe there would be too much political control. There's probably too much political control at the moment, and that would get worse.
Okay. I can't not touch on resources. So health is the largest single area of Scottish Government spending. It takes up between something like 35 and 39% of spending in 24-25. It's a share of spending that's grown significantly over time. There's a large increase in health spending in the 2000s. The spending per person on health was higher in Scotland than in either England or Wales at the start of devolution, but this gap has fallen over time. So in 1999, 2000, Scotland spent 22% more per person on health than in England, but by 2019-20, it fell to only 3% more per person. Nevertheless, the Scottish Fiscal Commission says that to keep up the demands of an ageing, less healthy population and medical advancements, Scottish health spending would need to grow by around 3% in real terms per year in the late 2020s and 2030s, compared with around 2% for all Scottish Government spending. Now, obviously, resources are at the centre of what we can do with the NHS, but it's a large share already of the Scottish budget. Costs are tight across the piece. The education budget is tight, the transport budget is tight, all public services are struggling. What is your kind of thinking on this? Is there a way, are there reforms to the NHS that won't involve more money, where we could actually, and I'm not going to talk about inefficiencies, but actually things we could do better? Maybe technology. I know the Chancellor today announced the idea of an integrated technological NHS down south, not something we seem to be making much progress on up here. Is that something we could look at that would maybe allow us to invest to reduce costs and make things more efficient in the longer term?
So yeah, definitely there's room for better technology. We waste a lot of time at the interface between general practice and hospitals, the primary secondary care interface. There's a lot of wasted time chasing things up back and forth that could be solved by simple apps and integrated records. So we certainly could save money by investing in technology. But I think we do need to invest more in the health service, but I think we have to be fair to the public. If they're going to be paying more tax, and they're already paying more tax in Scotland, then they need to see public services, including the health service, improving, not getting worse. And I can share, we in the BMA in Scotland, Scottish Council, we had a meeting where we discussed our approach to the national conversation. Now, we're not leading on this, we're just going to be a participant. But one thing that we unanimously agreed in that room, and that's doctors across hospitals, general practice, all grades, all ages, was that we need to be investing more in the community, more in primary care. Now, this is where there's a lack of honesty in Scotland, and not just Scotland, other Western countries. All the talk for the past 20 years has been about shifting the balance of care into the community and investing more in primary care. And we've done the exact opposite. And I think I could probably give you a figure of maybe around 2017, 18, maybe around about 10% was spent in primary care then, and it's dropped. I've got a GP in Nairn who's very good with these facts and figures. He says it's dropped to below 6%. So we have been talking about investing in the community, shifting the balance, and we haven't done that. And I asked the question, why have we not done what we said we would do?
Okay. Now, let me just move on to taking some comments, questions from the audience. I'm picking relatively at random. Ewan Cameron, you make a point about community pharmacy. Do you want to make that to us, if you're with us?
Yes, thanks very much, Chris. Really interesting what you've been saying, Ian. I think many people on the call is probably echoing your own thinking. My own thoughts are as part of the problem is we see the NHS as one thing when actually it's made up of many partners, and health is bigger than the NHS itself. And particularly in community-based health, where you have obviously primary care, but you also have other supporting agencies such as community pharmacy and third sector. Perhaps we're not fully utilising the resources that community pharmacy could bring to take some of the pressures off both primary and secondary care, and perhaps with some empowering them with innovation and technology might actually be a good way for innovation to sneak into the NHS by doing it outside the NHS walls, but being able to prove technology and innovation can actually work.
Yeah, I'm a huge fan of community pharmacies. In fact, I was at an event at the weekend where Community Pharmacy Scotland were there, and they were talking about something that you'll be familiar with called Pharmacy First and Pharmacy First Plus, where patients can get first point of contact care at pharmacists. And this practice that I'm in just now, we've got a pharmacist next door. I actually own the building, and we rent it out to a pharmacist. And my staff in the back office there, every morning, they are directing tens of people to the pharmacy, not just that one, but other ones in Inverness to get care. So we are already doing it in Inverness, and it's really successful, and it's hugely helped our workload. Major success. And I was hearing from pharmacists in Grampian who are doing something similar. The problem is, as you may be aware, workforce issues in pharmacy are significant. Pharmacists have come inside general practices as well to provide a pharmacotherapy service, and they're absolutely fantastic as well, been a real help, particularly with patients coming out of hospital and medicines change, something called medicines reconciliation, where we match up the drugs that patients come out of hospital and with their GP records. Our pharmacists are brilliant at doing that. So I'm a huge fan of pharmacists. I think pharmacy has been a big success. One of the few successes in the NHS in Scotland in the past 5 years, I would say, is pharmacy. And if we could increase the pharmacy resource in Scotland, that would be a huge benefit.
That's interesting. Okay, you'll know John Sturrock. John, you've got a question about the national conversation. Would you like to ask that?
Thanks, Chris. Yeah, Iain, you've been arguing, as you said, for a national conversation now since February last year, and nothing has yet happened. And so my question, two questions really. First of all, what shape should it take, and by whom should it be initiated? Should we wait for the government, or can it be started by somebody else? And secondly, how important is it that the conversation itself, or whatever shape it takes, includes a discussion of all the options, and that might include whether or not provision of healthcare remains free at the point of need, as both you and the BMA and the Scottish Government have argued.
And indeed, I think it was only last week the Royal College of Physicians raised that point.
Indeed, so
well, John.
Yeah, absolutely.
There's a hot potato for you.
Yeah, okay, so 2 or 3 questions in there, which I'll try to answer. John, come back to me if I don't give you a full answer. So when you ask what shape, I immediately thought of a circle. You know, I want everyone to be involved. In fact, I saw Neil Gray on the telly last night saying that he wanted to hear from all stakeholders. He mentioned trade unions, he mentioned patients, he mentioned healthcare workers. So I think everyone should be involved. So it absolutely needs to be inclusive. So the answer to the shape is round, circle. In terms of initiation, I think the conversation started, hasn't it? Because we've had one at the BMA, we're having this one here. John, you've contributed yourself, I've read some of your stuff. So there are conversations going on. So the penguins are chattering already, and everyone seems to think it's a good idea. So let me be bold and say the conversation has already started. But I would say that unless we have government backing, unless all parties, cross-party backing is there, I'm not convinced that it will be a success. I think you need to have that level of sponsorship to make it happen. Alternatively, we need a revolution. And a revolution might happen. It might get that bad, that if the government doesn't commission a national conversation, there may need to be some kind of public revolution, whatever form that would take.
Well, she heard it here first.
Yeah.
That's the first Reform Scotland event.
And in terms of, I tried to listen closely to your final question. So I think I've got it. It's about looking at some of the principles and the financing of the NHS. And again, Neil Gray on the TV last night, he said that one of his red lines was that the NHS should be free at the point of need. Now, the organisation that I represent, the British Medical Association, the majority view in the BMA is that we want an NHS that is free at the point of need, free at the point of delivery. We do have some members that would take a different view and would consider financing the NHS in a different way, including looking at some private healthcare options. And personally, and I think the BMA as a whole would say, we think all questions should be asked. So if there are groups that want to ask about private healthcare, let's have that conversation. Do I think we'll get a better health service if parts of it go private? No, I don't. I think parts of the health service will get neglected and pared down if we go down that route. So I'm a believer in an NHS that's free at the point of delivery, free at the point of need. That's not to say that I haven't paid for private healthcare for some of my family, because I have in the past couple of years paid for 2 members of my family to go private because I wasn't prepared for them to tolerate the current NHS waiting times.
Fascinating, fascinating. Okay, Paul Gillen, you've got a question about an ageing population and how we respond to that.
Yeah, hi there. Yeah, so I mean, well, it's pretty straightforward, I suppose. So yeah, obviously we do have an aging population. We all know that. You know, sort of on average, the population age is getting older. So I was really asking about, you know, how do we actually recruit enough consultant geriatricians, or get, you know, encourage enough people to go into sort of geriatric medicine, because, you know, obviously you know, older people generally do have more complex care needs, comorbidities, etc. So I just wondered, you know, how do we actually, you know, address the challenge, you know, from that particular perspective of having enough sort of qualified specialists to help, you know, to essentially to look after our sort of older population. Thank you.
Yeah, this is an interesting question, and I hope I've got the answer. So I think the answer is generalism. We need more generalists. You mentioned specialists, but the great thing about geriatricians is their ability to be generalists. They look at the whole person, all the organs in one, and that's what we need more of. I can give you an example of a patient that I'm seeing at the moment who's got a number of symptoms, and he's seeing one particular consultant at the hospital. And he came in to see me with another symptom that told me he potentially had a very serious disease. So I wrote to the consultant that he was seeing and asked if they might involve this other specialist at the hospital. And the letter came back to me saying, I'm dealing with this part of the body. Could you refer to another doctor for this? So I now have a patient seeing two different specialists that aren't speaking to each other in the hospital. And we've got to get away from that. We need far more generalists, and that means more generalists out in the community. So I'm a GP. I am going to say what we need is more GPs, not more geriatricians. But yes, we do need more geriatricians as well. But I would say we need more generalists. That's the problem. Health has gone down a very segmented specialist route, and it's meant that care has become increasingly fragmented, and the patient is often lost. So I would promote more generalism.
Okay. Sometimes hear people talking about a 24/7 NHS, and Nicola Hogan, you've made a point about a weekend waiting list initiative. Could you talk to that?
Okay, so I think.
Sorry, I was going to let Nicola just make
sorry.
Point. That's all right. If you're there, Nicola, anyway.
Oh, thanks. Yeah, thanks for hosting an interesting session. Yeah, just heard about this last minute, but I'm a consultant anaesthetist in an NHS hospital, so that was very, very interesting. Yeah, just on the topic of waiting lists, so I do often, maybe once every 6 or 8 weeks, work at one of these weekend lists, and yeah, at the time it seemed like a great initiative to help cut the waiting list numbers. We get through a lot of the kind of healthier patients, less complex procedures, but had been waiting maybe 18 months. However, I think yeah, these are going to be cut for the foreseeable, presumably looking at a way to restart them again. But I guess it's partly goes hand in hand with even the National Treatment Centre initiatives have been paused as well. So that's a kind of similar situation. And then even just the elective weekday lists, so the fact that some patients are waiting maybe 18 months and they turn up and they're maybe seen by a different consultant, and maybe the indication for their procedures change, and occasionally you get cancellations on the day because their indication has changed. So it just seems, yeah, as everybody knows, the longer the waiting list, the less efficient the whole service. So it's unfortunate that it seems to be quite short-term thinking, and a bit counterintuitive, just trying to save money, but not looking at the long-term picture.
Nicola, did I hear you right? Did you say you're an anaesthetist?
Yes, that's right.
Yeah, and your question is around your concern about the no longer having waiting list initiatives in action. Is that your concern?
Yeah, so yeah, obviously it just seems like yeah, there's not a lot of thought to the future, and these waiting lists were the initiatives, the elective lists at the weekend were cutting the waiting list, so it'd be good if we could get started again, but it just seems like a lot of short-term thinking and management at the moment.
Yeah, yeah. So I'm trying to think what most of my members would think, and there'd be a few different views coming through. So some members would be saying to me, yeah, waiting list initiative, throw money at the NHS, at health boards, once a year to improve the figures, but it all goes into hospitals. It never goes into primary care, so it's very hospital focused. So that would be what some people would say to me. Others would say, well, we're not incentivizing doctors to, they're already really busy during the week. Why would they come in and work at the weekend when many of them were losing money to do so because of their pensions? And the punitive taxation means it's not worthwhile. So a lot of my members, lobby me on that fact. They don't actually want to do waiting list initiatives because it's very poorly rewarded and has a negative impact on their well-being. But I think what I'm hearing from you is that this is something that you're prepared to do, and you see it as quite a loss. And certainly sounds as if patients will be suffering by the loss of these waiting list initiatives, because obviously they're going to have to wait longer. So I think there's a few facets to that issue, but yeah, the whole point that you're making about short-termism is well made, and that's why we need to have greater permanent investment in the workforce so that we don't have to depend on waiting list initiatives.
I've just got one last question, if you've got time, Ian, from Nicola Gordon at RCN Scotland, and it just touches on a point I didn't get to make about improving population health and health, illness prevention is something we've been hearing about for decades. I'm sure we have made some progress in that, largely through changing lifestyles and whatever. But Nicola, would you maybe just give us your thoughts on that?
Hi, thanks, Chris. Can you hear me okay?
Yes, we can, yeah.
Yeah, and hi, Ian. Yeah, just a very quick observation there. I agree with everything you've said. It's been a really interesting call. I lead the policy team at Royal College of Nursing, so our perspective is slightly different, but what you've said resonates with the nursing profession as well. So we're really conscious, obviously, nursing and midwifery is the largest workforce in the NHS, but we don't really want a situation where we're continually calling for more and more and more doctors and nurses and other clinicians, because the imbalance across the workforce in Scotland and the proportion of the Scottish Government's funding that would go to health and social care would be so significant. So improving population health is really what we see as key. There's a few comments in the chat about the ageing population, and while I agree with those, we shouldn't automatically assume that getting older means having poorer health outcomes or being in worse health. So would you be keen that the conversation includes that perspective around improving population health, basically healthier outcomes, and making sure that people live in good health for longer, and therefore driving down demand on the NHS? Thanks.
Yes, absolutely, Nicola. And I think it's inevitable that the conversation will focus a lot on prevention, and people always raise prevention, and everybody thinks, what a good idea. And then everybody thinks, quite difficult to change people's behaviours, costs a lot of money, takes a long time, politics is short term, don't get immediate results. But yeah, absolutely, we know that the big things, smoking, alcohol, drugs, obesity, exercise, many of which have got worse during the pandemic. Many of my patients have become deconditioned during that time. They've all got worse. And the other thing that often gets thrown in, and I think would get thrown in a national conversation, is we hear calls for people to take more individual responsibility for their health. Another controversial area, and this practice that I'm in, although it looks quite plush, we look after quite a deprived population, and I have patients regularly sitting in front of me who smoke, who drink, who take drugs. And when you look at their medical file, you can see why they've got into that position. It's the family they were born into, it's their location. And you know, when I hear people saying take more responsibility, I think, well, right, if you were born into that situation and you developed those addictions, would you be seeing the same then? But yeah, absolutely, prevention, public health, it's got to be a major focus of any national conversation.
Okay, thank you. We're out of time, I'm afraid. There've been so many great comments, good questions. I haven't got to. I don't think this is the last time we're going to do this with Iain and with others. And as I said, our NHS 2048 programme is there on the website. We'd be delighted to take contributions from anyone that's interested in doing it, but we'll have to call an end to it there. Iain, thanks so much for being so frank and thoughtful. Really interesting, quite distressing in places as well, but I think there's an awful lot to think about there. So it'll certainly give Reform Scotland food for thought going forward, and I'm sure the audience as well. So thank you for your time. All power to your elbow, and thanks to you and the audience as well for joining us today.
Thanks, Chris. It's been a real pleasure. Thank you.
Thanks a lot.